are members of Ortho NorCal and have a particular interest in hip pain and hip disorders. And we're going to talk about different facets of hip pain and hip disorders today. And I'm going to begin by talking about some of the disorders that I treat as a sports medicine physician. My background is in orthopedic surgery and a fellowship training in sports medicine, specifically arthroscopy, and I have a particular interest in treating athletes as well as in treating sports-related injuries. And a lot of that involves doing arthroscopic surgery as well as evaluation and management through physical therapy and other modalities to improve hip and other joint function. Hip arthroscopy, specifically as a sports-related injury, is somewhat new in comparison to other joints in the body, specifically the knee and the shoulder, which have received a lot of attention over years as being joints related to sports-related injuries, and hip is a little bit newer. So I'm going to talk about some of those concepts that have come about in the last decade or so. To begin with, let me see if I can advance the slide here. Hip anatomy, I thought just as a quick primer, it is primarily a ball and socket joint. As you can see, and I don't know if my cursor shows up on the screen. If it does, great. If not, then I'll just talk through what I'm looking at. But looking at the diagram here on the left, it's a cross-sectional through the hip joint, which is what we would refer to as a concentric ball and socket joint. What that means is the socket goes clearly around the ball in such a way that it covers up most, but not all, but most of the ball in such a manner that we say it's concentric, it goes all the way around. The different layers of the joint include the bony anatomy, of course, which we'll see on an x-ray in a moment. But in addition to the bony anatomy, what allows a joint to articulate or run smoothly and touch another bone is cartilage on the surface of the bone. And you can see that depicted there on the picture on the right. The shiny surface that we see on the articular part of the bone is what articulates or touches the shiny surface on the adjacent bone. And so you have cartilage touching cartilage. And that's what makes a joint so fluid and pain-free. You're bone with a layer of articular cartilage, we call it, on the surface of the bone. And so you have articular cartilage, or the white articular cartilage, on the surface of the ball, and that connects or attaches to the articular surface of the bony articular cartilage of the socket. The manner in which they interact is actually quite smooth and quite ingenious. If you look at if you look at the coefficient of friction, which is a number that the physicists use to describe how surfaces interact with one another, the coefficient of friction for cartilage touching cartilage is actually slicker than ice on ice, and that's what makes these joints so fluid and the motion so fluid. When we evaluate patients with hip pain, one of the first things that orthopedic surgeons do is take an x-ray, and this is an x-ray, a typical x-ray that you would see of a hip. And what I like to tell patients when we're looking at x-rays, we get a lot of information about the bone, but we get information about some of the other tissues as well. Specifically, when we're looking at an x-ray, as much as we're looking at the bone, we're looking at the space in between the bones, because that tells us how much cartilage somebody has. So you can see clearly on this x-ray that whereas you see the ball and you see the socket above it, there's a dark space in between. And the fact that those bones are not touching each other leads us to believe that there's a sufficient amount of cartilage in between those two. And so you can infer from that space how much cartilage a patient has. And in order to draw the contrast, in this next photo, you see now we're looking at a right hip. On the picture that's labeled as a normal joint space, you can see once again good joint space between the ball and the socket. And in the adjacent picture, that is what we would refer to as an arthritic hip, specifically osteoarthritis, which is arthritis caused by the loss of the cartilage. And as the cartilage is worn out, the bones get closer and closer, and eventually it can lead to end-stage arthritis, which is what we're seeing in this photo, where it's bone rubbing on bone. And you can see the bone gets very white. We call that sclerosis. It's a hardening of the bone, which is a reaction of the bone in response to the fact that it no longer has the cartilage there protect. Now, Dr. Cagle is going to talk primarily about hip arthritis, and so I wanted to bring this concept up as it's one of the first things that we think about and talk about when we talk about hip pain. Athletes, however, get a variety of other problems related to the hip that are not related to arthritis. So we're going to defer hip arthritis to Dr. Cagle's talk, and I'm going to talk a little bit more about two other entities. Specifically, what I want to talk about today is bursitis, which you see at the top of this list here, as well as hip impingement, which goes along with a torn labrum. And I'll talk a little bit about that. Going back to the picture that I showed before, the labrum is a connective fibrous tissue which forms a ring around the rim of the socket, and you can see that in cross section on the picture on the left, and you can see it end on the picture on the right, and that actually is demonstrating a labrum tear, and you see that line demonstrating the labrum where the labrum itself appears to be peeling or tearing away from the bone. What is meant by hip impingement refers to the bony architecture of the hip joint, the femur, and the acetabulum itself, whereby growths of the bone can actually lead to the hip impinging, or the bones bumping up or making contact with one another in a pathologic way that leads to a further damage. So I'll talk a little bit more about that looking at this diagram. Generally speaking, every joint in the body, quote unquote, impinges. That is to say, when you reach the end of your range of motion of that particular joint, that's because the bone is impinging on something, preventing the joint from going any further. There is such a thing, however, as pathologic impingement, which means that in certain positions, a joint should be able to obtain a certain position without having bone making contact with another part of the bone. What we see here in this diagram is an indication or a cross-sectional area of the hip joint. On the far left is what we would refer to as normal anatomy. You see the femur bone, and then it's articulating or joining with the pelvis or the acetabulum, which is the cup of the hip joint. What's demonstrated here in pink is a soft tissue, that cross section of that labrum. Again, that labrum is a ring of fibrous tissue that goes around the rim of the socket. I generally tell patients, I sort of compare it to almost like being a gasket or an O-ring that goes around the rim of the socket. It does aid in maintaining the joint fluid and lubrication inside the joint itself, similar to how a gasket would function. When we say hip impingement, it usually refers to bony growth on the either side of the joint, whether it's on the femoral side, which you see depicted there in the picture in the middle. The extra or additional bone growth is depicted there in red, or you can have additional bone growth on the edge of the socket. Now that can come in a couple of different forms. One way is that the labrum itself, which should be a fibrous tissue, actually can calcify and turn into hard, rigid bone. And so if you imagine this hip going through a range of motion, as the hip flexes up or rotates, that bone, that extra bone that you see depicted there in red, will impinge or bump up against the adjacent bone, whether it's the additional bone of the femur bumping up against the labrum on the pelvis, or in the case on the right-hand side, the additional bone on the pelvis bumping up against the neck of the femur. And what that does is it causes pain. It causes a pinching sensation. And we'll talk a little bit about what some of the presenting symptoms are in here in just a moment. The concept of hip impingement has gotten a lot of attention just in the last 10 to 20 years, but it's actually not a brand new concept. It's actually been recognized going far back as 60 or 70 years ago. First reported even further back in 1936 by Smith Peterson. Looking at it, it's something that was recognized but not necessarily treated as a pathologic entity, especially if you consider that the concept of sports medicine or surgery or medicine in general to improve sport performance isn't something that really gained popularity until the late 70s or through the 80s. So once again, the hip impingement, it comes in generally two varieties. We say it's either impingement on the femoral side, which is referred to as a CAM, and I'll show you a reason why. That's either referred to as a CAM deformity or a pistol grip deformity. And what you see here on this picture, the shaded area is the excessive bone that's grown there. So that would be the pathologic part of the bone. In the pincer deformity, the extra bone is actually on the side of the pelvis at the edge of the acetabulum, where it's actually grown an overgrowth of bone there, and that actually impinges or pinches up against the neck of the femur. In both cases, you do see tearing of the labrum as you go through a range of motion or repetitive range of motion. You can actually get peeling of the labrum away from the bone, which eventually causes significant pain, specifically in those positions, but can cause chronic constant pain as well. So referred to as pistol grip deformity. If you see this picture, I'm moving the pictures around a bit here, but essentially, if you were to draw a line down the center of the femoral neck here, what you would generally expect to see, let me just, is it should be symmetric, or they should be mirror images, one side to the other. As you can see here, there's a white arrow pointing to the excessive bone. That should actually be a concave surface, but it's convex on that side, much like the pistol grip of an old pistol, and that's how it got that name, or it looks like the cam of an engine. And that excessive bone is what impinges on the edge of the acetabulum, or the edge of the cup in the socket, and specifically pushes up against the labrum and causes the peeling, and it can also cause damage to the articular cartilage. Again, the second form is excessive bone on the edge of the socket, which grows and impinges on the neck of the femur as it goes through a range of motion. This is an arthroscopic picture that demonstrates the damage that can happen to the cartilage with specific types of cam deformities. Essentially, what happens is, as that extra bone grows, it rides when you go into hip flexion, or you move the hip into a certain position and flex the hip. That bump of bone goes past the labrum and creates additional pressure on the cartilage, such that the cartilage begins to peel away from the edge of the bone. Seen in a number of different sports. I typically see this in sports in which there is quite a bit of dynamic range of motion about the hip joints. So we see it in martial arts quite frequently, but interestingly, especially where we are in Santa Cruz, we see it quite frequently in surfers and skateboarders. Again, a lot of dynamic movement about the hip in forceful manners. We'll also see it quite frequently in sports where there's an excessive amount of crouching. The typical textbook answer there is you see it in a softball catcher or in a hockey goalie who's squatting down in a hip flex position. There's a number of studies looking at the origins or the etiology of this as well, and it is quite clear that it is something that develops over time with repetitive positioning, and it's been demonstrated that sport-specific motions such as squatting or certain pivotings do or are a predisposing factor to developing these deformities. Most common thing that we see is pain. There's something called the impingement sign, which I'm going to demonstrate here in a minute, or show a photo of in a minute. The presenting symptom is pain right in the front of the hip, in what we call the inguinal crease, or the top of the hip joint where the thigh meets the pelvis. There's a sign called the C sign, where it's actually quite interesting that the patients very frequently come in and they turn their hand upside down and make a C, and they say it hurts right here, and they demonstrate that. And it's actually described years ago that this was called the C sign. It's one of the more common signs that we see, but we'll also see a number of other clinical signs, including limp. You can start to see some early signs of arthritis if it's been going on for long enough on x-ray. This is one of the typical tests that we do in the office. So when a patient comes in and is describing pain in the hip, we get an x-ray. If we see a deformity such that, similar to what we're seeing here in this x-ray, where you should see a mirror image concavity of the femoral neck, or where the femoral head meets the neck on the top part of the femur, but there's an extra bone growth there. And the way that you can cause an insult to the labrum or reproduce that pain is by flexing the hip up, like the clinician is showing here in the middle picture. That's what we refer to as the impingement test. Flex the hip up and rotate the femur in internal rotation. By doing that, you're actually taking that extra growth of bone, putting it in direct contact with the area where the labrum is torn, and rolling it underneath it. And that generally reproduces the pain. And if that specific maneuver causes pain in the individual or in the patient, that's indicative of a labrum tear caused by the hip impingement. Number of other clinical tests have been shown, but with probably less specificity for this. Something called the figure 4 position, which can cause stretching of a torn labrum and can cause also be indicative of a labrum tear. I'm going to skip some of the biomechanics, but there's been a number of studies looking at how it affects your gait. Suffice it to say here that there's significant effects on the core strength, range of motion, and the gait mechanics as a result of not just the impingement, but the tears of the labrum itself. The x-rays themselves are quite helpful. We've already seen a number of x-rays looking at what we would call an AP or a frontal view. Looking at a lateral view, you can actually measure the degree to which the bone deviates from the norm. There's a concept called the alpha angle, and what that does is it takes the femoral head and makes it into a circle and then draws an angle from along the axis of the femoral neck to a second point where the point at which the neck deviates from the circle of the head. That is significantly increased if there's extra bones there. So if you see an alpha angle greater than 50 or 55 degrees, that's indicative of a pathologic increase in bone in that area. And so that's one of the radiographic things that we'll use to diagnose this. Ultimately, we will generally get an MRI scan. MRI is helpful for not only diagnosing the amount of extra bone, the location of extra bone, but specifically we can now start to see the soft tissues. Specifically, we can see the soft tissues of the labrum, and that's indicated there on the slide on the right-hand side. Again, if you remember seeing the cross-section that we looked at previously, where the labrum attaches to the bone, because the labrum is made primarily of collagen, it should show up as a solid black structure on the MRI, whereas in this case, it shows up full of white, and there's a white line stretching across that area, and that's indicative that the labrum has peeled away from the bone due to the, or in other words, a labrum tear, due primarily in part to that excessive bone seen there by the white arrow seen on the right, on the photo on the left. Once again, some additional pictures of what an MRI, this will be a frontal view of the MRI, where it's indicated as a large cam lesion. Once again, you have excessive bone growing over the femoral neck at the junction where the head meets the neck. Again, it should be essentially a mirror image of that concavity that you see on the bottom half. So where that bone rolls in, it's going to cause pathology to the labrum and start to make the labrum peel away from the bone. So when we first evaluate a patient, the treatment is primarily consists of a regimen of physical therapy. Not every labrum tear requires a surgery to address. We generally start with the most conservative approach, and we generally say most pathologies have a spectrum of treatment. The spectrum of treatment goes from the least invasive to the most invasive. Physical therapy is designed to improve overall core strength, the strength of the muscles around the hip, and help to avoid certain positions. That being said, there are mechanical problems associated with specifically with hip impingement that can't be addressed by physical therapy, specifically the excessive bone growth. The labrum tears themselves do not heal. As a general rule, most soft tissue tears that are within a joint, whether it's a rotator cuff attachment in the shoulder or an ACL ligament tear in the knee, or in this case, the labrum tear in the hip, once there's a tear within a joint, it generally does not heal on its own, meaning it doesn't reattach itself. But that being said, the symptoms can become quiescent. And so if you can get excellent function, range of motion, and eliminate the pain with physical therapy, that's always the first plan. If a patient fails a decent regimen of physical therapy, consideration could be given to arthroscopic surgery. And essentially what we've done here in arthroscopy is develop a way in which we can enter the joint with a fiber optic camera and address the pathologies. Specifically, we can put the camera inside and assess the amount of damage to the cartilage, to the labrum, and address both of these specifically by repairing the labrum, meaning reattaching it back to the bone. And in the case of the excessive bone, again, which we do consider to be the etiology or the cause for most of this problem, by addressing that by shaving that bone away. As you recall, I said at the beginning, the nature of the hip joint itself, because it's what we call a concentric joint, such that the socket goes all the way around the ball, it does present a specific challenge to hip arthroscopy, meaning there's not much room to get a camera inside of a joint when the socket goes all the way around the ball. And because of that, as you can see in this operating room photo, the patient actually has to be placed on a traction table, and you actually have to pull traction on the leg enough to get the ball slightly pulled away from the socket to make room for the arthroscope of the camera and the instruments to get inside. So what we do is we try and address the excess bone by shaving it away. And here's a before and after picture of hip joint. One with the cam deformity that we see there on the left-hand side with the arrow, and one where we've tried to create that same concavity on the superior surface such that it's almost a mirror image of the other side. And we talked about labrum repair. On the left-hand side is an arthroscopic picture of a young soccer player that we treated for a hip labrum tear. You can see that I'm pushing with my metal probe on that labrum, and it's bending into the joint. What you can't see is around the corner there that the labrum is completely detached from the cartilage as well as the underlying bone. So on the right-hand side, we've put stitches in, and those stitches are attached to plastic anchors, and those are inserted into the edge of the cup, the edge of the acetabulum, such a way anchoring the labrum back to the bone in a very rigid manner. For a long time, the general treatment of choice was arthroscopy with what we refer to as debridement, meaning just cleaning up. Until technology caught up with the concepts of repairing a hip labrum arthroscopically, there wasn't much that could be done other than to address these pathologies, other than to look at them and do a general cleanup. But as I mentioned, now the standard of care is to repair the labrum. As you can see, the labrum repair had 90% success rate over 67% success rate with debridement alone. And I'm going to jump ahead here, just take a final picture or a final photo of just the hip impingement, looking at what it looks like to do an osteoplasty. On a similar patient, as you can see, there's an extra convexity of bone there on the left-hand side. We're looking at a left-hand hip. We've already repaired the labrum with some sutures there. And what we've done on the right-hand side is we've now taken what I like to refer to as an apple bite. If you think of taking a bite out of an apple and eating it down to its core, you're essentially creating that concavity there such that when that patient now flexes their hip up, there's no longer that excessive bone that will push up against or molest the labrum. And this is what it looks like from a side view, a before and after picture of the excessive bone on the left-hand side there, and appropriate amount of what we would call osteoplasty or resection of bone on the right-hand side. Final thing I'll mention is the concept of hip preservation, which we were just talking about just right before this, and it's an interesting, Dr. Cagle and I were talking about, it's an interesting concept. Ideally, a lot of what we do when we do it arthroscopically, whether we're talking about arthroscopy to address torn meniscus in your knee or torn ACL in your knee, arthroscopy to address a labrum tear in the hip, is the idea of preserving the joint, preventing arthritis from occurring in the future. It's a very noble idea, but it's one that doesn't have any scientific data to necessarily back it up. So in other words, we generally like to think that by addressing pathologies within the joint, we're hopefully preserving the hip such that it does not go on to develop arthritis and need a hip replacement in the future. But that being said, the concept of a labrum tear as a precursor to arthritis, or for that matter, in the knee, meniscus tear as a precursor to arthritis in the knee, whereas there's some evidence to suggest it addressing those pathologies either by meniscectomy in the knee or by repairing the labrum in the hip. There hasn't been any direct scientific proof that it does eliminate or delay the course of arthritis or delay the need for joint replacement in the future. Generally speaking, then, what's the purpose of doing it? Well, the purpose of doing it is to alleviate the symptoms and bring about a functional joint, whether it's a functional hip or shoulder or knee, such that a person can engage in the activities that they enjoy doing, whatever brings them joy in life in the present time. And the idea of hip preservation or knee preservation, for that matter, is something that's going to be an ongoing investigation. It's going to take probably decades to really determine, because it's something that you have to follow a cohort of patients over for decades in order to determine. Pretty much taking my time, so I'm going to just jump really quickly through hip bursitis, and then we'll turn the time back over to Leah and open up for some questions. Last thing I wanted to talk about is hip bursitis. Frequently, I get patients coming in complaining of hip, and they point to the outside part of their hip, pain with ambulation, but more than anything, pain sleeping on that side, and they're worried they need a hip replacement. We get x-rays and they've got no arthritis whatsoever. And essentially what we see, and one of the other primary indications for hip arthroscopy is bursitis in the hip. And what that means is inflammation of a bursa sac. A bursa is a flat, empty sac of tissue that is situated all over the body in various places, and it's usually in a place where there is a potential for friction, whether it's a bone rubbing on a tendon, or two bones rubbing close to each other, two tendons rubbing close to each other. We have a bursal sac that's supposed to eliminate friction. In the case of the hip, it's the iliotibial band, the IT band, which runs all the way from the pelvis all the way down to the tibia, just past the knee. And that tendon, which is sort of a flat sheet of tendon, it's not tendon like a noodle, but more like a sheet of paper, rubs right over the edge of the outside part of the femur called the trochanter, and it causes irritation. So one of the other things that we do in hip arthroscopy is address that. Obviously, once again, physical therapy is our first line of treatment, trying to stretch that IT band out so there's not so much pressure and tension. When that doesn't work, you can inject it. You can inject a corticosteroid injection. The way corticosteroids generally work is they stop the chemical reaction that causes inflammation, and that's how they work as an anti-inflammatory. If you do that, and you do that in combination with stretching and physical therapy, the majority of patients will get better. And when that doesn't work, there is an arthroscopic surgery we can do where we actually open up a window in the IT band, as depicted here. You make a little slit there and you open it up into a window. And essentially what you've done is you've taken the pressure off the tendon rubbing on the bone. You can vacuum out the bursa, and you leave that part open, and it takes the pain away. It's one of surgeries that I enjoy doing, and the reason I enjoy doing it is because the success rate is so great. The patients get better probably 90-95% of the time, and it's really a good feeling to let them know that you don't need a hip replacement. It's a pretty simple problem, and it gets better, like I said, most of the time with an injection or therapy, and as a last resort surgery. So with that, I'm going to conclude and open it up for some questions, and I'll turn my screen off here.
All right, we're now ready to accept questions. We're moving into Q&A session. So if you have any questions, please address those by clicking Q&A button on the bottom row. I do have a few questions to start with. A question, what precautions do I need to take after my surgery?
So for the hip arthroscopy with the labrum repair, specifically if you do any shaving of the bone, there's a couple precautions, and there's a few different viewpoints out there. I'll give you my viewpoint, which is a little bit more on the conservative side, but every time you shave bone, you do weaken the bone to a certain degree until such time as that bone heals itself. If you're shaving that extra excessive bone, that bone will be weakened. The body doesn't know the difference between that and a fracture, so it's going to heal that bone just fine, but it's going to take some time. if you were to put full weight on that, or if you were to fall, theoretically you could get a fracture through the femur. So generally speaking, for hip arthroscopy, anytime I'm shaving the bone, I do put people on crutches for about 4 weeks. We let them bear weight, about 50%, but as long as they keep the crutches on, it just slows people down well enough that that there's no risk of fracturing through the femur or femoral head. So it'll be crutches for about 4 weeks. That being said, we also start physical therapy relatively soon. So you'll be in therapy working on getting on a stationary bike, going through range of motion and core strengthening exercises.
Thank you, Dr. Haywood. Another question. Give me 1 second. Are there any risks or complications from having hip arthroscopy?
Just like any surgery, all surgeries carry some level of risk. The standard risks of any surgery apply for hip arthroscopy, and that would be things like an infection. Now, an infection in hip arthroscopy is very rare, less than 1% chance. Injuring a nerve or blood vessel, very rare, less than 1% chance. The main risk that we see with this type of surgery, with an arthroscopic surgery in general, is that in spite of having a quote unquote successful surgery, that you can still have symptoms. In other words, it's another way of asking, well, what's the success rate for the surgery? And the success rate for these surgeries varies depending on demographics. Specifically, younger age tends to do better. Isolated pathologies like a labrum tear or cartilage injury without severe arthritis tend to do better. And in those cases, it's about an 85 to 90% success rate, meaning that 85 to 90% of the time, the patients are satisfied with results and would consider doing it all over again. So there are some other more rare complications considered. Again, you have to put patients in traction. So occasionally you get irritation of the sciatic nerve by putting a patient in traction. Occasionally you get some numbness in the groin area, and that happens more with the men than it does with the women for 2 reasons. Number one, with the men tend to be more muscular, so you have to apply more pressure for traction. Number two, with the scrotum right there in the groin, when we're pulling traction, there has to be a post right up against what we call the perineum. So you can get a little numbness in that region, but generally speaking, that resolves within a couple of days. So that's the general idea. The usual complication rates apply, but the main thing with all of these arthroscopic surgeries is what's the chance of success? And the chance of success is not 100%, but it's more in the range of 85 to 90%.
Thank you.
And on that note, if I can also, coming from the other side of things, from a surgeon who does, this is Robert Cagle, by the way.
Yeah.
For someone who does, hip replacement surgery, to echo what Dr. Haywood was just saying, it's important that you have someone who has good indications for surgery, and age can be misleading. So just because you're a young individual doesn't mean you don't have significant arthritis.
Right.
So I get a skewed patient population in my practice for people that have had hip scopes and didn't do well. And then I see them, it's like, well, even though you're only 40 years old, you have pretty significant arthritis. And it's not that you didn't have, whoever your surgeon may be didn't do a good job, but maybe the indications weren't quite there. So when you ask about a complication and going on to hip replacement, that's a very common question I get asked. It's all about indications. You have to have very little to no arthritis in the hip joint. And the problem with getting MRI scans, if it's not an orthopedist who orders them, everybody who has an arthritic hip, every single arthritic hip has an associated labral tear, bar none. You can't have a normal labrum in the setting of severe arthritis. So that's where it becomes important when you're thinking about surgery in the form of a hip arthroscopy, that your surgeon like Dr. Haywood would suggest is that it's about indications and make sure that it's not for arthritis. A lot of people who go on to fail hip arthroscopy were probably people that shouldn't have had it in the first place because they just had too much cartilage damage. And I see a lot of referrals from, not Dr. Haywood, but other people in the area that maybe push the indications a little bit. So that would be my word of caution, is just because you're not 70 years old doesn't mean you don't have significant cartilage damage.
Yeah, I think the idea, and Dr. Cagle makes a good point, is it's so tempting to say, well, it's an arthroscopic surgery, you don't really burn any bridges. it's less invasive, so let's try that. But it's not without its complications or side effects. And so just because it's a less invasive thing doesn't mean it's the right thing to do to start with. And if you had significant deterioration, the evidence is actually really quite clear on this. If you have significant arthritic changes or loss of joint space on the x-ray, the chance that an arthroscopic surgery is going to improve that is almost zero. Again, the indication for the arthroscopic surgery is pretty much isolated labrum tears, early cartilage damage, but specifically to do an osteoplasty to remove that excessive bone, repair the labrum. But once that cartilage is worn down to a point where it's noticeable on the x-ray, it's probably too late to do our hip arthroscopy.
Okay, thank you, Dr. Haywood. Another question. How many physical therapy visits do you recommend after you decide I'm a candidate for a surgery?
That's a fair question. I mean, there probably isn't like a single number that's been shown, but I would generally, if someone comes in to see me, I would generally have them see a physical therapist for about 8 sessions over the course of 4 to 6 weeks. And by that point in time, I don't expect the problem to have been solved necessarily, but you should get an idea of what direction this is headed in. Patients come in pretty much knowing that they're headed in the right direction or that they've plateaued or headed in the wrong direction at that point in time. So I think somewhere between 6 and 8 visits of physical therapy would be sufficient to know which direction it's headed in.
Okay, thank you. Another question. If I already been told that my labrum is deteriorated due to arthritis and my hip is bad and needs to be replaced, is it worth to see a doctor for a second opinion, or is this clear cut?
Great question. So if the x-ray showed that the joint space is significantly narrowed, if it's bone on bone or very close to it, it is pretty clear cut. As Dr. Cagle was mentioning, I think the chance of a hip arthroscopy being helpful in that case are very low. So the second part of the question is actually really quite an interesting question too. At the age of 49, there's arguments to be made on both sides of joint replacement early versus joint replacement late. The way that I counsel my patients usually is I tell them, on the one hand, if you get to a point that on a daily basis you're having to modify your activity or eliminate activities that you would otherwise be doing, otherwise like to do on a daily basis because of that hip or because of that knee, then it would be a reasonable time to consider doing joint replacement, whether you're 49 or whether you're 69. Now, the young age at 49, that comes up a lot, and people ask, well, how long does this joint replacement last? And I think Dr. Cagle is going to address that to a certain degree, but I'll give you my opinion. How long does it last, and shouldn't I wait as long as I can to have my joint replaced? The counter argument to that is this: why would you sacrifice a younger decade to live in pain through your 40s or 50s with the idea that it's going to improve the longevity of a joint replacement in your 70s and 80s? In other words, don't limp around and be in pain and miss out on all the joy that you would like to have while you're in your younger decades, just because of this concept of you don't know how long a hip replacement is going to last. So that brings me back to my initial point, which is if you get to a point where you lost significant quality of life, the things that bring you joy have gone away or have been significantly altered because of this hip, then I would consider doing it. And once again, because if it can bring you back to the things you want to do, if you haven't gone hiking or ridden your bike for months because your hip hurts too much, think of all the bike riding you can do for a decade rather than limp around for a decade, hoping that you're going to delay hip replacement. And then you've spent a younger decade of life, I don't want to say miserable, but definitely not happy. So that's the counter argument. And I don't know if Dr. Cagle has an opinion there as well.
Yeah, I would echo the same thoughts on that, is that You know, the nice thing about the hip replacement world we live in right now is that we have made such tremendous advances, not only in the technique of putting them in, but as far as when we talk about how long will my hip replacement last me, am I too young for it if I do it now, is the hip replacements we're putting in now, you know, the technology that we have has been around a little over 10 years as far as the really advanced plastics that we have and the ceramics that we use for the bearing surfaces. And the lab data that we have, where if we stick these hip replacements in a cadaver hip and then put it through testing of 24 hours a day, 7 days a week, and basically simulate, you know, 20 years of use, if we take those components out and look at them, there's virtually no difference. You have to measure the wear in microns, so like literally 10 to the minus 6 meters, a very, very small amount. And if you look at that data and compare it to the lifespan of a person, you know, if we have a plastic bearing surface that is typically considered the wear point in a hip replacement, and if it wears out that slowly at 3 millimeters thick, we're looking at literally probably hundreds of years of lifespan of that plastic. And unless we make some significant advances in cardiology or something, we're not going to outlive these hip replacements we're doing now. So it's very common that I have patients that come to see me that are, you know, in their 40s or 50s, and they're asking about, you know, should I get my hip replacement now? And I would echo the same sentiments. It's like, and the other thing is that, you know, if you wait 10 years, there's no guarantee that you're going to be here. You know, car accidents happen, you know, it's just there's a lot of unknowns out there. And why would you trade time that you have now for time that you may have later when you're older? And especially if the hip replacement is going to last, you know, far out then there's a good chance you can have one surgery in your 40s and it'll probably live longer than you will. And that's assuming you put it in correctly and you don't have some devastating complication, which, you know, knock on wood, I've been very fortunate. I haven't had any significant infections. I haven't had any dislocations or the typical reasons why people have hip replacements redone. And that's because, as I'll get into in my talk later, you know, I believe in, you know, high precision surgery with robotics and all the excellent technology we have today. So the long answer kind of made short is, I think that when you have your hip replacement is a very personal decision. And it's when you feel like taking on, you know, the rehab and the risks of having surgery versus the benefits of surgery. And I tell people, you know, most of the time, you know, when you're ready, and I'll be there to help you when you're ready to make that decision.
Thank you, Dr. Cagle. One last question we have here for Dr. Haywood. The question is, if you have moderate to severe arthritis, will PT help you with range of motion?
The short answer to that is probably not. Almost never. The cause of loss of range of motion when you have, you know, take severe arthritis is multifactorial. One of the main things is actually the tissue around the joint, which is called the joint capsule, actually gets thicker and more fibrous and more rigid. It gets stiffer, and no amount of physical therapy is going to stretch that out in any type of meaningful way. You could potentially improve it to a certain degree momentarily, but it's going to rebound back the way it was. Also, the large bone spurs that form around an arthritic hip, also the fact that a bone touching a bone, that surface contact is also quite stiff and difficult to improve upon. So the short answer again is no. What benefit therapy does help with moderate to severe arthritis preoperatively is it improves your gait mechanics to a certain degree. You can improve your balance and the strength of the muscles and the gait mechanics, meaning the manner in which you walk to a certain degree, you can improve that. But the range of motion of the hip, no.
Okay, perfect. Thank you, Dr. Haywood. We are welcoming Dr. Cagle right now to start his presentation.
Perfect. Well, again, thank you for everyone who's, you know, tuned in and trying to learn about hip, you know, pain in both, you know, arthroscopic versus open treatment. Again, my name is Robert Cagle, and I'm proud to be here at OrthoNorCal. And my specialty is basically open surgery in the form of joint replacement of both the hip and knee. So a little bit of my background, you know, I come from the Midwest. did my orthopedic training after medical school at Indiana University at the Cleveland Clinic Foundation in Cleveland, Ohio, and then did a hip preservation slash sports fellowship in Indianapolis, and also a upper extremity trauma fellowship in Switzerland for my post-orthopedic residency training. And currently I have 3 hospitals that I go to for affiliation in hospitals in Los Gatos and the Fremont Surgery Center, where I perform all of my surgeries. And then just a little bit of personal background, married with, beautiful wife and 3 wonderful children. And kind of my passion in life is keeping people active. And as you can see there, I'm very into fitness and triathlons and trying to stay active and keeping my patients active as well. So to kind of move on from what Dr. Haywood was talking about, the non-bony changes where you don't have erosion of the cartilage and bone spurs and all things we're talking about before. Now we're talking about where the cartilage is now being frayed and gone, and we're seeing bony reaction. And, if you had to say, a stereotype patient population, this is typically older individuals, but not necessarily, and we'll get into that later, but arthritis is definitely the leading cause of disability amongst, the elderly population over the age of 65. About 20% of the population is living with arthritis of the hip or knee. So if you're in one of that patient population, don't feel bad. There are many other people out there with you. And I always kind of want to start with that just to kind of set the tone that it's not an uncommon problem, and you're definitely having your peers out there that are experiencing the same problems you have. Now, so what are the kind of the symptoms of arthritis of the hip? Well, the things that are very common that most people know about, is chronic ache and pain. And to kind of talk about what Dr. Haywood was saying with the presentation of that pain, it's typically in the front of the thigh or in the groin. So the problem with the hip is they call it the great mimicker. There's a lot of pain around the quote hip joint that to a layman is hip pain, but when you talk to an anatomist or a surgeon is, possibly coming from the back, or like trochanteric bursitis as he was talking about. But true arthritis or a problem within the ball and socket joint itself classically presents, in the front of the hip, around the groin or the front of the thigh. And associated with that, you can sometimes get heat and swelling, you can get stiffness, your joints may feel like they're locking. Also, I've had plenty of patients that feel like their hips, quote, dislocate out of socket when they have arthritis. Sleep disruption is probably one of the biggest determining factors of when people feel like they're ready to undergo a hip replacement. And then I always want to mention that there are psychological symptoms that people have to deal with. This is not purely a body ailment, a musculoskeletal problem. The fear of surgery and depression that's associated are definitely real problems. Now, how can you try to prevent arthritis? That's a great question. Well, you can't obviously get younger. It's a function of age. The longer we live, the more pressure we're going to put through our joints, the more they're going to wear out. However, if you can keep your weight down, that is probably the biggest modifiable factor that you can do to not only try to slow or prevent the progression of arthritis, but also prevent the symptoms of arthritis. We know that by simple physics, the more weight you put through an arthritic joint, the more inflammation you're going to cause, the more it's probably going to hurt. And then, of course, traumatic events in life. If you dislocate your hip, that can lead to severe cartilage damage, or even where the hip hip ball itself can die, called avascular necrosis. So try to avoid getting hurt, keep your weight down, and then try not to get old. But what are our treatments for arthritis of the hip? Well, there's basically 2 broad categories. There are non-surgical treatments of the hip, which focus around trying to keep active, keeping your weight down to try to minimize the symptoms. There's dietary supplements that you can try. Physical therapy, again, to try to strengthen the joint. Getting more range of motion of the joint is very difficult when you have a true mechanical problem with a bony impingement with all those bone spurs that we were talking about. We can talk about joint injections, in the form of cortisone. There's aids such as canes or walkers. If you have leg length discrepancies related to the arthritis, you can try shoe inserts. And casting, well, I put that on there pretty much for historical purposes at this point. But people used to do that long before there were hip replacements. However, when we talk about surgical treatments, there's 2 categories of that. There's kind of open, where you use incisions and make not through the camera type surgery, and then arthroscopy, which uses a scope to get into the joint. That has a pretty limited role for arthritis, as we kind of touched upon. You know, if you read the literature on, you know, doing arthroscopy or putting a scope into the hip joint when it's arthritic, those patients usually don't do very well, and some of them can actually do worse because you're now actually traumatizing an already inflamed arthritic joint. Biologics, you know, I get asked about stem cells and PRP very, very frequently when it comes to our treatment of arthritis. You know, there's no good studies out there that show that it delays or prevents the progression of arthritis, and insurance companies don't pay for them because they're, quote, experimental. People that I have done, you know, biologic treatment on, the form of those kind of injections on, you know, it's typically they're not a candidate for surgery, and they can afford the extreme cost of them, and they're literally ready to try anything. I usually try not to advocate for them because I just don't think I've seen a good track record without any significant evidence to support it. And when we talk to people, ask about partial treatments of, you know, hip replacement, that's usually related to fracture care, called like a hemiarthroplasty. And hip resurfacing, I touch on it now because if you look at a hip resurfacing model versus a replacement, it's a metal on metal replacement. So occasionally I get asked about, hey, can I just have my hip resurfaced? I personally don't like hip resurfacing, and I used to do a lot of it in training, but I haven't done any of it since I've gone into practice for myself, mainly because of the huge complication rate that comes from metal on metal bearing surfaces. So what I kind of focus on for treatment of arthritis, and will be the bulk pretty much of my practice, which in my hands is probably about 70% of what I do, is hip replacement surgery. And that's what we'll try to focus on after we go through some basics of, you know, non-surgical care. So again, pain relievers in the form of anti-inflammatories, or, quote, NSAIDs. You know, those are the anti-inflammatory drugs. You know, cortisone is really the only thing that's FDA approved right now for injection into the hip joint. Everything else is kind of off-label if you're talking about the, quote, gels, the hyaluronic acid injections. And if you are non in the osteoarthritis is the, quote, wear and tear type of arthritis, but there are, you know, the autoimmune style arthritides, such as, you know, rheumatoid arthritis or psoriatic arthritis. Those are where they start having DMARDs, you know, the powerful intravenous drugs, or, you know, steroids that you take chronically. And that's kind of outside the realm of what I do. That's more of a rheumatologist. And like I said, when people are thinking about surgery, it's usually they've tried extensive treatment non-surgically, or they're just ready to say, I want the problem fixed. So again, what Dr. Hay was saying about when everyday activities are painful and you're tired of modifying your life around your pain to get through your day, pain during sleep or prevention of sleep is probably the most common thing I hear of when people are like, you know what, I'm done, I'm ready to have my hip replaced. And such other treatments such as physical therapy don't really work. Or if you're having medication side effects, you know, stomach upset, kidney trouble, you know, acid reflux disease, or even bleeding ulcers from chronic anti-inflammatory use. So this actually just came out within the last year, that a poll of patients, you know, 90% of them found that they waited too long for a joint replacement. And that subsequently led to, in the patients that waited too long, an increase in depression, deconditioning. You know, you actually gain weight because you're more sedentary, because moving around just hurts too much. And typically when you have those three things happening, it leads to a poorer result when you do decide to take up, you know, replacement surgery. So just some numbers for what the outcomes are going to, or I'm sorry, the incidence is going to look like in the future. You know, most of the models that we read are going to show this huge increase over the next decade. You know, the increase is almost going to double of hip replacements by 2030, and over 6 times increase for knee replacement. And that's just because people are looking to stay active longer, and they're not willing to put up with their pain. And the old dogma of like, well, you're too young for hip replacement, come back when you're 65. You know, people like me and others are kind of challenging that old dogma. So again, this is just more of a graph representing that. Now, the prevalence of hip replacement surgery, it's, you know, I would say in the United States, the last numbers that I saw were from 2018 that were published. It was over 300,000 hip replacements are done a year in the United States, and over 10 million people are living with osteoarthritis of the hip, and it's the most common cause for hip replacement surgery. And again, that just echoes that. And again, societal trends, infant demand, aging population. The increased prevalence of obesity is definitely contributing to, as I mentioned, the physics of why we're wearing out our joints faster. And then, of course, people don't want to give up riding their bike and going mountain biking or hiking or whatever their active lifestyle wants to do. So we perform hip replacements to try to get people back into their life. I kind of make the joke with most of my patients that I'm not saving lives most of the time, I'm saving lifestyles. So the main goals are to relieve pain, obviously, enhancing the joint stability, and helping get better range of motion. And in a lot of patients, lowering their leg length. I see commonly people that come in with up to an inch of leg length discrepancy related to arthritis, plus maybe they were born that way, and we can fix that through a hip replacement. And then, of course, restoring the offset, which is the biomechanics of how the hip works. So what exactly is a hip replacement? Basically, there's several parts that go into it. The acetabular cup right here, this is the portion that goes inside the pelvis. And then we have that gets placed inside of that, the plastic liner, which is called highly cross-linked polyethylene. It's a very advanced, very durable plastic that we're using. And the femoral head here is pink, not because we like the color pink, but because recently we found that ceramics, if you blow them up under a microscope, are actually smoother than metal and have less friction when they articulate or move around in that plastic surface, so they generate less wear. And then we have the titanium stem that goes down inside the thigh bone we call the femur that we place the ball on. Now, again, this is kind of a cartoon of what Dr. Hay was talking about. Bone spurs, or osteophytes, is the medical termination for that. Basically, the bone has two options when it sees the increased load from the loss of cartilage. Again, as he said, cartilage has a friction less of ice on ice. And when that goes away, the bone doesn't exactly get happy about that. And it can do two things. It can make a bone spur, an osteophyte, or it can erode away and make a bone cyst. And then the X-ray here next to it is kind of it's an X-ray of what a hip replacement typically looks like. And this one just so happens to have a screw. I typically don't do that most of the time. I would say less than 10% of the patients do we have to do that. Most of the time we can get such a good press fit with the high precision replacements that we do nowadays that's not necessary. And we'll get to that in a little bit. And that's using the robotics that I'm a big believer in. So, and how do we get into the hip joint? So there's a lot of controversy out there. What's the best way to do it? My bias is, I do an anterior approach, which is, quote, I don't really like the term minimally invasive. I would say less invasive is probably a better way of doing it. Any way we're doing a hip, it's still, we're making an incision, getting down to the bone and putting in metal. So there's some amount of invasiveness to that, but it is definitely less invasive compared to the traditional posterior approach, where you're making a longer incision and detaching some of the rotation muscles on the back side of the hip. I typically do an anterior approach, and even a modify on that I do a bikini incision where we don't disrupt any of the muscle attachments on the hip itself. We go between the muscle planes to try to minimize the trauma and get people up and moving faster. So again, this is kind of the traditional anterior approach here on the front. This is kind of your traditional posterior approach. And then we here at Ortho NorCal with me take it one step further in the fact that I do a bikini incision. This is a patient that was young and healthy and was kind enough to allow me to take a photo a year out from her hip replacement. And this is her surgical scar, if you can see it. Because we're cutting in the natural lines of the hip joint itself, the scars are almost hardly visible a year out from surgery. And it just makes it so much more cosmetic, number one, but also less invasive and more tissue sparing, number two. So to kind of get back, what's the history of, robotics and hip replacement and all this stuff that we're talking about? So, hip replacement surgery kind of came, with Dr. Charnley out of the late 50s, early 60s, and didn't really become widespread and probably until the 80s. And, that was based on a static plan. And then when technology started coming more into the game, we started doing navigation to try to increase our precision. Then we applied that to freehand tools with navigation, in the early 2000s. And then the robotically assisted surgery kind of started, around 2010 or 2011, when we started using it in the hip replacement realm. So why is that important? Why do we want to increase our precision? And the way we do surgery is because we know that if we can put the implants in correctly, they're so good nowadays and will last so long, then we just have to worry about malposition, loosening, and dislocation events. Those are probably the biggest reasons we can try to prevent having hip replacement fail, in the form of now the plastics are better, which leads to less debris and which causes the metal to get loose. And if we put them in correctly, there's a far less dislocation risk, especially coming from the anterior approach, which inherently is more stable. So like I said, in my hands, to my knowledge, I haven't had any of my hip replacements dislocate to date. And I haven't had any that I've had to revise for dislocation events or malpositioning. Now, there's other smaller things like leg length discrepancy that we can help with robotics. And also the big one that we can't avoid, that we try to avoid as much as possible, I should say, is infection. If we do everything correctly and patients are optimized and have everything as well as possible, it's about just under 1% if you look at all the studies out there for risk of infection. So extremely low, but not zero. But all these other ones we can really help with good surgery and good, good approaches into the hip itself. Again, this is kind of what it looks like when you have poorly, constructed plastics from 20 years ago that we have huge advances on now, where they don't crack and break like they used to, which leads to failure. And again, this is what a hip replacement dislocation looks like on an X-ray, extremely painful. And we've known that coming from the front, doing an anterior approach is more stable, combined with the correct positioning and high fidelity, or hitting the mark every single time of what you're trying to do with putting the components in, we can avoid this terrible looking X-ray and having to go to the emergency room to try to fix this problem. So the platform that I use for robotically assisted total hip replacement is the Mako, and it's just an absolute game changer when it comes to hip and knee replacement. So basically what it is not, I always want to make sure I point this out to people, it is not where the robot's doing surgery and your surgeon would be off in the corner just drinking coffee saying, wow, great job, keep it up, and let's go for another one. Basically what it is it's a tool that we can use in our hands to increase our precision and get better outcomes through putting them in correctly every single time to decrease our outliers. And you can do it very easily through a direct anterior approach like I do, but you can use it for other approaches as well. And like I said, it's been around since 2010 for the hip replacement, so we're coming up on the 10-year mark, and it's just been an absolute game changer as far as just being able to go to bed at night knowing you did the very, very best procedure you could for your patients. And this is kind of what it looks like intraoperatively when you're planning on doing a hip replacement. Is you get a CT scan, which builds a three-dimensional model of the hip itself. You input that into the computer, and then intraoperatively, we can do things to kind of check how the bony anatomy matches that CT scan, and then input that into the software to where we can guide down to the degree of precision of how we put both the cup or the acetabular component or the femoral stem in to make sure that we do a good job and give you the best possible outcome you can have. So again, this is kind of what it looks like from a model of the knee, the hip, and how we use it to prepare the bone for putting in the implants. And the outcomes after, robotically assisted techniques, you can see here, this is the target line for this study. And the ones that are outside of the box were actually planned on that based on the 3D CT scan software, showing that based on the individual anatomy, we can customize your surgery. And maybe you don't want to have this normal box where 80% of the population should be. Maybe you should have a little bit more version, as we would call it, on your cup, or a little bit more inclination based on your anatomy. So these points that are outside the box were actually on purpose in this study. And the same thing for this, again, robotically assisted total hip, much tighter grouping for what we're shooting for in that study versus having outliers, which is what we're trying to avoid. And these are the patients that are at higher risk for dislocation events. Even though small in number, these are the patients that you want to try to avoid and having to go to the emergency room with dislocation events. So again, accuracy of cup orientation down to literally the single or double degree of precision, both in the plane of rotation and how you place it in the depth of the cup into the pelvis. So this is how it's expanded since I've been doing it over the last few years, just really coming to the market, and lots of peer-reviewed studies to go for it as far as to prove that it does work. And this is actually a patient of mine who is 2 weeks out from her her hip replacement on the left and 2 months out from her hip replacement on the right. So I hope this audio works just to kind of show you how she was doing after her hip replacement. So it's not, so I'll paraphrase it for you. Basically, she is talking about, she is an avid horseback rider, likes to go out in her barn, and she was tired of having, you know, her biggest complaint was actually the range of motion. She couldn't get in the saddle as easily anymore. And it was causing a lot of groin symptoms in combination with that. So we staged her hip replacements by 6 weeks apart. And this is her 2-week follow-up from the second one, showing that she is now walking with no limp, you know, nice full symmetric swings without any ambulatory aids as far as a, you know, crutch or a cane or a walker. So no disrespect to Dr. Haywood, but when we do hip replacements, we can bear weight fully right out of the gate, actually encourage you to walk frequently in a short distance, you know, every single hour, get up and use it and get used to your brand new hip. And that's actually excellent therapy for the hip replacement after surgery, is to get up and move on it. And when you don't need a walker or a cane is when you don't need it. We just don't want you falling. That's the only requirement that we have. So to kind of sum it up, you know, hip replacement surgery is a very, very successful operation, and it strikes millions of people every year as far as arthritis, and you don't have to live in pain with it. It's actually the #1 procedure in all of medicine as far as outcomes from patients at 1 year from surgery saying, I'm glad I had surgery. Why did I wait so long? This really changed my life for the better. And now I can get back to my activities such as horseback riding or going on hikes or cycling or any of the other activities that you want to do with your life. And excuse me, and I'm just very fortunate that I'm able to perform the surgery in orthopedics through this great technology that we have and get people living the lives that they want to have again. So at that point, we'll open it back up for some Q&A as far as if people have some questions about how the hip replacements work or whatever you want, to be happy to talk and go from there.
Thank you, Dr. Cagle. I do have a question addressed. How long do you stay in the hospital after the surgery?
Excellent question. So I would say that in my hands, probably my overall patient population from everybody, all comers, probably 50% of my hip replacement patients go home same day from surgery. I do a lot of these surgeries now at the surgery center where they leave the operating room and my average length of stay is 6 hours. And that's at the Fremont Surgery Center that I mentioned earlier. In the hospital, again, probably a third of my patients go home same day. And that's just simply a function of, can they work with therapy before they go home for the day? Because to be able to be discharged from the hospital, you have to be eating, drinking, you have to use the restroom and go number one basically. And most importantly, you have to pass your therapy. And if you're getting done with surgery at 1 o'clock and you're in the recovery room, by the time you get up to the floor, it's 3 o'clock. The therapists are, they're already done for the day, basically going home. You don't get seen till tomorrow. Most people, barring significant medical problems or issues, there's a lot of people that can go home same day. And if they don't go home same day, they go home the next day. I'd say 99% of my patients have, less than 2 nights in the hospital, and a lot of them go home the same day.
Thank you, Dr. Cagle. Another question. How long does it take to get the surgery done?
So how long does it take for me to put the implants in? It's a function. There's, the little old lady who is 70 years old compared to the 40-year-old bodybuilder that wore out his hip are two totally different patient populations. I would say it ranges anywhere from about 45 minutes to an hour and a half, an hour and 45 minutes, depending on the muscle tissue, because what I try to do is be very respectful and try to minimize the soft tissue damage, which sometimes, if there's more of it, takes more time. If the question is related, like if I see you and I want to have my hip replacement, how long does it take for me to have that done? It's typically around 3 to 4 weeks, assuming that there's no medical problems or problems that you need to, quote, get cleared for surgery for. So again, to kind of recap on that, if you're a healthy person and doesn't need any significant tuning up, as you would say, to get onto the operating room schedule, it's usually pretty quick within 3 to 4 weeks. Or if you're talking about how long does it take to perform the surgery, somewhere between 45 minutes to an hour and 45 minutes.
Thank you, Dr. Cagle. Another question. What is recovery like after hip replacement?
Excellent. So it's much better than knee replacement. So, virtually all of my knee replacement patients I send to physical therapy. I would say less than 5% of patients that I do hip replacements on actually see a physical therapist. And the overall mantra that I would tell people for hip replacement surgery with me is that less is more. So most people feel significantly better even a few days after hip replacement surgery. And I usually have to try to slow them down more than I have to try to get them to do more. So what I do, what I tell my patients, and this has worked for me extremely well, is there's basically 3 things that I want you doing for the first 6 weeks. So the first thing is just some basic physical therapy exercises that are focused on just training your muscles to contract again and help circulate the blood to prevent blood clots. And that's simple things like calf raises and clamshells and glute squeezes. So that's number 1. The second and probably most important thing you can do after hip replacement is walking. I tell my patients for the first 6 weeks after hip replacement, if you can walk every hour, and it's not long walks, I'm not talking about a mile, it's 50 to 75 feet to start, and then progressively increasing that distance as your body allows you to do it based on your pain. Do that every single hour while you're awake, and then when you're sleeping, get good healthy sleep as best you can through the night, and then you restart it the next day. And then the third thing that you do is simple, just pedaling on an exercise bike or a pedaler on the floor. You start with 2 minutes a day of virtually no resistance and slow pedaling at around 60 RPMs. You're not doing exercise. You're not checking your heart rate monitor. You're not trying to build up sweat across your forehead. You're doing therapy on the hip. And you do that progressively increasing your minutes to try to build up to 30 minutes by 6 weeks, and then you don't go past that. If you do those 3 things, 95% of patients won't need a physical therapist and will do exceptionally well for the overall outcome. So that's the first 6 weeks. At the 6 to 12 week mark, that's typically when we get an x-ray in the office, if everything looks good and things are going great. Now I tell you, okay, now we can start exercising, and I want you to each week gradually increase your activity as your body dictates, with the goal by 3 months that you're back to an exercise program, you're golfing, you're doing whatever you want. And that's kind of an average. Some people do it much faster. Again, the overall goal is you listen to your body and increase your activity as your body tolerates, because like I said, you're not going to break the titanium metal implant that we put in there if you go too hard, too fast, which is easy to do with a hip replacement because a lot of times it feels pretty good. You can just inflame the soft tissues around the hip, like the quad muscles or the hamstrings or your abductors on the side of your hip. And that's usually the problem that I have with most patients, is trying to slow them down so they don't become their own worst enemy.
Thank you, Dr. Cagle. One more question. How much pain will I have after surgery?
Great question. I would say, for most of my patients, I give, a multimodal pain approach utilizing, non-narcotic medications with anti-inflammatories and Tylenol, and then also narcotics. I would say most of my patients that I see, they take, pain pills in the form of narcotics for, a few days up to a week. And most of them, when I see them at the week follow-up, are like, I'm on Tylenol now. Is that okay, doc? I'm like, that's great. I don't want you on narcotics. And if you don't need pain pills, don't take them. But there is a spectrum to that. A lot of people, have a high tolerance for pain, but there's other people that don't, and that's okay. We'll help you with pain pills and get you through it. But I would say most people do very, very well with a hip replacement. And this is far different than a knee replacement. I tell my patients that have had a hip replacement and then are coming to me for their knee that you've kind of been spoiled. The knee replacement is probably going to hurt way, way more than your hip replacement did, and it's going to be a tougher rehab. So that's why I'm very fortunate to do hip replacement surgery, because the patients usually do so well and their pain is actually pretty well managed with non-opiate medications. And most people are getting back to golf and activity somewhere between 6 and 12 weeks from a major surgery like a hip replacement.
Thank you, Dr. Cagle. Last question here. What are the possible complications of this procedure? What are your complication rates?
Yeah, so I would say the big complications that we want to avoid are infection in number 1. The way you try to do that is you have to have, quote, optimized patients, or that you're cleared for surgery. And the biggest one for that is don't be a smoker. Smokers have a much, much higher complication rate for infection and just overall complication rate, such as blood clots, which we'll get into, and diabetes management. If you're poorly controlled with diabetes, you're not a good candidate for surgery because you're going to have a higher complication rate in the setting of an infection. So that's probably the one that I would, knock on wood, I don't want to, jinx myself here if you're superstitious, but I haven't had one of my hip replacements get infected. I would say the next biggest problem classically with hip replacement surgery is dislocation events. And I think with proper implant positioning and better surgical techniques that I employ, I've been very fortunate that I haven't had any of my hip replacements dislocate. So that's a potential complication that I've been fortunate not to have. The other potential less severe complications are like leg length problems. That classically was a much harder thing to get really, really accurate when you're going through the backside of your hip or a posterior approach because you're laying on your side. So when I do an anterior hip replacement, you're laying flat on your back, and it's much easier to gauge your leg lengths very, very accurately and still take you through a range of motion. So I do things a little different than most anterior hip surgeons. So I don't use a fracture table, where probably 95% of anterior approached hip replacement surgeons use that. So I do it with your legs free, you're not under traction, you're laying flat on your back with both legs draped out, so I can grab both of your legs and move them independently of themselves. And I do it through, again, an anterior approach with, the bikini incision, so that decreases the complication rate as far as a wound breakdown or something like that. I would say my complication rate in my hands that I can think of right now, I've had with probably close to 1,000 hip replacements now, no dislocations, no infections, no catastrophic nerve or artery damages. I've had 5 superficial wound infections that were treated with antibiotics, and I've had 2 wounds that broke down before I switched to the bikini incision. That was one of the reasons why I switched to the bikini incision and tried to learn that technique and kind of popularize it here in the United States, is because it's a far superior way to get the skin to heal. And since I've switched to that, I haven't had any more wound breakdowns as far as the skin opening up or any problems. My leg lengths are usually within several millimeters of each other, and knock on wood, I haven't had anybody have any medical complications as far as heart attack or stroke. So that's, again, in my hands, what I can attest to. But classically, the number 1 was infection, number 2 dislocation, and then leg length discrepancy, number 3.
Okay, thank you, Dr. Cagle. On this note, I would like to thank everyone for joining us today. If you have any questions, please email us at marketing@orthonorcal.com or call 408-412-8100. The recording of this webinar will be available on our website. Feel free to watch it over. And thank you again, and enjoy your evening. Thanks, Dr. Cagle and Dr. Haywood.
Yes, thank you, Leah, for setting this up, and thank you, everyone, for tuning in and listening to us. We really appreciate it.
Thank you.
Thanks so much.